So for your patients who are TM primary, which means that you have to decompress them both day and night, you'll need a day appliance. So in this case, we've picked PMT. Actually, that's my favorite because it is the thinnest material that we have, and with only a very thin layer of acrylic over it. And that acrylic is designed to wear out. We want this acrylic to wear out at about a rate of 3/4 of a millimeter every 2 months or so. And in that way, then we can transition from the original vertical that you need from day one to the point at which it's not there 12 weeks later. So don't be concerned as you go through the treatment that you develop areas that are worn through or openings, because that makes absolutely no difference. It's just an easier transition from your starting point to end point. It doesn't mean that this needs to be replaced or returned back to the original dimension. If you do that, you're just making it more difficult for them to transition back to the dentition. So, and this is optimal because this appliance is designed to be functional. That means it's to be worn all during the waking day. So the patient must eat with it, speak with it, and in order for them to wear it, they have to be able to speak as well with it as they did without it. And so it's delivered not just to the centric stops that you would for most appliances in this way, but as importantly, it has to be fitted so that it doesn't alter speech. So one of the first things you want to do is just run your fingers around the device to see if there are any areas that are sharp, that have a contour that are greater than the teeth. If you notice that the occlusal surface of these is quite narrow, previous versions were quite wide, and the thought process being to produce a table. But if you do so, then you're more likely for the patient to bite a cheek, and certainly more likely for them to have speech difficulties. So we've evolved to just having centric contacts and have the occlusal surface as narrow as possible. Basically, you're just taking the tooth and elevating it to the proper dimension. And if you look at the device, then with a person who has a cant of the mandible, then the phonetic should write that, and you should see that there is a greater thickness on one side than the other, which means you've corrected that cant. Okay? So the very first step before you put it in their mouth is run your fingers over all the edges. The areas that are most likely to affect people's speech, and we use sibilant phenome to be able to discern that. So we ask the person to count from 66 to 77, and that's where the tongue will come down against the lingual surface of the lower anterior teeth. And at that point, we can discern any speech problems, because likely if the contour of the lingual surface of the bicuspid or the first molar is contoured out towards the tongue, then that will immediately be a speech impediment that has to be relieved. So just run your fingers over. Are there any transitions? Are there anything that is rough or sticking up that might be issue? Okay. And remember, you really don't want contact on the distal marginal ridge of the last tooth, because in that way, that'll be the first point of contact. So this is important for you to have these delivered in that way. You also don't want to have the first bicuspid higher than the second bicuspid, because if you have the first bicuspid higher, that will be an impediment in lateral movements, in chewing, and in speech. So, it isn't really necessary if you have one of those step-offs where the bicuspid is lower than the cuspid. Don't have the acrylic come up to meet that first bicuspid. All that's going to do is increase facial tension. So you want that second bicuspid to be in contact. And really, if all you have are these three teeth, the second bicuspid and the molars in contact, that's fine. And really, all you need is a stop. That's all this is for. So you're not replicating proper mastication. That's not its purpose. It's to decompress. That's what its function is. And there will be some cases where there aren't any posterior teeth. So in that case, what you'd want to do is never cantilever greater than a bicuspid-sized tooth off whatever is the anterior tooth. So if you have only cuspids, 3 to 3, then only have a first bicuspid cantilevered, and that's it. Don't ever go more. And if you have to cantilever anything, then make sure that the labial surface is carried all the way down to the gingiva, so you have good frictional resistance. Because if you cantilever all the way to the back, there'll be torquing action, and that might loosen up the front teeth. So it is not necessary to carry these all the way back. You just need a vertical stop, and that's really its purpose. Okay, and so that's step one, to check for those. So in this case, this is a very smoothly rounded device, and it doesn't appear that I have any interactions there. You want to run your fingers over the top of this, because then you can find if there's any protrusive interferences, which we don't want. I feel that because of the angulation of the second molar on the right-hand side, that there is going to be a distalizing closure right here in this transitional ridge. So I know that that's going to be a problem. So what you want to do is take one of your burrs here. These are all cross-fluted, so they're designed, as Matt was saying, about for the vinyl, or for the type 12 nylon versions, but they can also be used for acrylic just as easily. And so for these purposes, any of these might work. And I'd probably go to one that has more of a rounded tip for the purpose that we're going to do right now. So pop that guy in. And so the first thing I'm going to do is relieve this little portion right in here. Okay, so in this situation, what I did is I simply took that transitional marginal ridge out. You leave your centric contacts, never touch those, but the transitional ridges, if your finger can't freely flow, then remove that interference, okay? So now this feels pretty good. You do have a little bit of a lingual anatomic ridge here. That's to protect the contralateral side condyle in lateral movements. That'll be important for maybe the first week or so until inflammation's reduced and then elliptical chewing is restored. Future adjustments would be to lean this wall out as time goes on. Centric stops are rarely changed over the life of the appliance, so very few adjustments are necessary to this as time goes on. Okay. Prior to insertion of the device, after you've gone over the day appliance to make sure that that all surfaces are smooth, interferences, anything that you can think and feel before you try it in the patient is to be completed, along with your check to make sure that vertical is correct. Now, when you get ready to bring it to the patient, you have to reproduce the same relationship that you created when you took the phonetic bite, if you expect this to all be the same. This is a physiologic technique, so therefore we have to remove the inflammation in the jaw, reduce the pain, so that the muscles can relax, so it'll have the same trajectory, so that when we try in the appliance, we'll be replicating the phonetic bite that we started with. So to do so, we use a ASA MP5 laser with 808, 905 wavelengths, and we do the standard 30 seconds lateral, and so this laser is reducing inflammation. So the first part is you just have them close, and you do 30 seconds in this position, and then open, please. And with tiny little movements like so, then you do 30 seconds in the posterior joint space. So every time, in every position, you're always slightly moving the device. Okay, and then go ahead and close for me. And then after 30 seconds, now you're going to go in the pathway of the superficial masseter. So the superficial masseter runs from the maxillary zygoma to the gonial angle. So you replicate that same position for 30 seconds. You would do this so 90 seconds on one side, 90 seconds on the other, 3 minutes total prior to delivering the appliance. And if you had situations where the patient was having an issue with speech, where they're speaking out of the side of their mouth, there are sometimes we have to dilate the nose with some kind of nasal dilator like mute or the nose cones in order to replicate how these things are going to fit together. All right, so just count from 66 to 77.
66, 67, 68, 69, 70, 71, 72, 73, 74, 75.
Then you used an equalizer for 20 minutes prior to taking your bite registration. The important thing is to do exactly what you did to take the bite, so that now the trajectory of occlusion will be the same as what was generated for this appliance. So the first thing you want to do is insert, and then always just try to get it slide right over the teeth like so, and then press one side and then the other, and it's good to hear that snap. And then make sure, like you tried before earlier on the models, to push front and back to see if there's an AP rock, and then lateral. As you can see, there's absolutely no rock in there. Okay, so you can rest aside, but don't bite into that. So before you ask them to bite, you want to have them count, and they need to count from 66 to 77. And somewhere along the way, you catch them in that trajectory to see if there's any prematurities in the occlusion. So I'm going to ask you to count now. Can you count for me from 66 to 77, please?
66, 67, 68, 69, 70.
Open 70. Wide and close. Open wide and close. Open wide and close. Wide and close. Okay, so you can see there's a bit of a slide there. Okay, so can you go ahead and count for us now? 66,
66, 67, 68, 69, 70, 71, 72.
Open wide, close. Wide, close. Wide, close. Wide, close. Okay, so now you can see that she's dropping right back into position. Does that feel even on both sides? Mm-hmm. Yeah. So that's really all the adjustment. So that simple, just one little spot that I adjusted, and now it's even. And that's really all you need to do. If you don't have a laser at this point, you could do a P5 test where if you just had an equalizer and you want to be sure that this is proper, then you do a P5 test where you put your hands out and hold in this position and go ahead and check. Okay, and so now the important thing is to show the patient how to take this out, and you want to make sure that the speech is relatively the same, because this is as thin as is possible to make an appliance. So always good to share with the patient and how to take it out, and always show them to put a finger as far back as is possible and lift up. And then you can go ahead and remove the appliance. Now, to be sure that you have speech the same, have the person count without it, put it back in, and see if things are the same. So go ahead and count for us from 66 to 77.
66, 67, 68, 69, 70, 71, 72, 73,
so
74.
You can see as she's counting that her tongue is right, the transverse width of the arch isn't great enough. Her tongue is always pushing against the front teeth. Can you bite all the way together, please? And so then that's why she has an anterior open bite. Go ahead and swallow for us. Sorry, go ahead and swallow again. You see how that tongue just goes right into that void. So speech, swallowing, everything, she has that anterior tongue thrust. So these patients are going to be more difficult But you really couldn't make this any more narrow than it is right now. So you can go back and double check, and then remember just to set it on top, click one side, then the other, make sure it's seated. And again, please go ahead and count from 66 to 77.
66, 67, 68, 69, 70, 71, 72, 73, 74, 75.
So you can see the difference in her speech. So with the double sibilant in the 66, 60 range, that there's a tiny little difference, but by the time she gets to the 70s, you really can't tell the difference. And at that point, I don't think I would adjust this any further. But if there was really a slur in the speech, then then you would check right here in the lingual surface. This would be an area to adjust. Those are already so thin and so contoured. I really wouldn't do that. I would just let her accommodate to it. And if her speech is that clear after just 20-30 seconds, then believe me, after an hour or so, she'll accommodate to it, and there really won't be any differences. If you have situations where you put this on the patient and they talk about it feeling tight on the front teeth, then what you absolutely don't want to do is adjust the front teeth. To adjust the amount of tension on the front, you must go to the distal of the most posterior tooth, because the friction is from the posterior tooth to the anterior tooth, and so if you want to lighten up the front, you have to cut back the back. So you would take this line right back here, and you would just keep relieving it very, very small increments until you took the tension off of the front. And then when you have the proper amount of fit and tension, as Matt described, because it should have good resistance to pop off of your smooth appliance the printed model. And remember, the stone model, it should fit very snugly, and that's the way it should fit with the patient. So these are just some adjustments per comfort of the patient until you can get it to snap right back on. Okay. So for this patient, we want to deliver a almost night positioner. So not only do we have a discluding element here, but we also have this ring that prevents retrusion of the mandible. So in order to have the proper alignment, these are fitted together in such a way to correct whatever cant problems the mandible may have, so that as the person comes together. Otherwise, we used to, back in the old days, just make an upper, but if the teeth that it opposes were crooked, or you had one anterior higher than another, then that would be the sole tooth that would absorb all the tension and could actually cause it to loosen up. Now we use full coverage. We have the proper angle for this fit, and now we can have equal distribution. Now, if your patient wants these kinds of nasal dilators, then these can be adjusted per patient with a special curvature to them that allows for movement in any dimension. Okay, so same thing as the day. We insert the lower implants, and again, always go in at an angle like so, and then set them on top, place pressure on one, then the other, and the appliance should not rock and feel snug all the way around. Okay. Now for the nighttime, the way you do this with the nasal dilators is it must be rotated in. So you place it like so, and then rotate it like this, and then make sure the lip is out of the way before you place it into position. Now you ask the person to close, and now you can see that these are fitted together. The important part is to make sure that it does not touch in the posterior area. So if you're not sure, put some articulating paper back there, have them grind around, and then you can adjust that for them. As simple as this. So you'll have them, open all the way, and then go ahead and close. Just grind around there. Good. And you can see it slides right out. And then in the back, go ahead, bite, and you can see it slides right out. So we have no issue there. This is having anterior disclusion, so it decreases the elevator muscle contraction by 70%. so that if a person tries to clench like this, the mechanical component will be working while they're sleeping. And of course we know that because proprioception at night goes to the cerebellum, not the cerebrum, a patient can bite 5 times harder at night than they can in the daytime. So this is why this becomes necessary. Now I'd like to explain how to adjust the nasal component here. Go ahead and close, please. So the object is that people have a compromise in this area, then a Caudle's maneuver would be able to open it. So these have been unadjusted, and I'm going to demonstrate how to adjust these. And you can only adjust these after you have sprayed the patient's nose in order to dilate it, depending on what their sensitivities are. So you may have a myriad of different solutions that you might need in order to do so. So we use Clear, which is a hyperosmotic saline, and that works very effectively for daytime. There's the rescue version of Clear, and there's also a 12-hour version of Clear. So that's hyperosmotic saline and xylitol. The rescue version has oregano and some eucalyptus, and then the 12-hour has Afrin and xylitol. So we have those individually. There's some people who suffer from hay fever and these kinds of things. So antihistamines like phenylephrine and neosynephrine might be needed. There are some patients where we need to use tetracaine and phenylephrine in order to nasally dilate and be able to keep them open. And there also is the different kinds of essential oils that we have as a proprietary blend. So there's all the different things that you might need in order to start the process, and so this is what you're going to need to do prior to insertion. So now you've sprayed her nose, and now you have to adjust these. But see, if these are people who have nasal valve compromise, where internally it's pinched valve, you can't evaluate it externally by looking at the nose. You can only see this by x-ray, and that's why we use a CBCT. In our office, we use the ICAT Flex because it's the most reliable of all the machines that I've had contact with. And so right here, we'll see that these have been unadjusted. Excuse me, I'm just going to lift your lip up a little bit here so that you can see how this is up against her tissue. And this has a special little bend in it so that we can, it's a 3-dimensional wire, so we can rotate it, lift it, basically any direction. But this is too close to her, so what we need to do is bring that tab away from her and up, and that's how we explain it to the patient and show them how to adjust it. So you'll notice that the bumps are down here, so we need to get them up here. Okay, so now with the patient having nasal spray of whatever type is necessary to open up their nasal passages, we've adjusted one side so that you can see how it is distended here. So it's taking the tissue and pulling it this way to open the nasal valve, whereas the other one has not been adjusted. To adjust, you show the patient how you simply get your finger under the pillow, pull away from the patient, okay? So you always want the first movement to be away, and then the second, is up. So up and away is how you adjust it, and then you can relax there until you get the adjustment at the level. So that means they probably just need a little bit more there. You can just lean back, please, thank you. And then you get it until you have the proper distension. So are you able to breathe now? Okay. So you just adjust it until they can. So there's a point at which it's ideal. If you go past that, then there's just friction and it's too much, and then you can just bend it back. But you show the patient how to do this, and I always show them to put their thumbs under the tabs, push away from them and up until optimal. And then that way at night when they're sleeping, if it gets bent down because the pillow is pushing on it, that they can then just adjust it for themselves and go back to sleep. So this would be ideal situation. Thank you.